Good evening and welcome to the Rural Medicine Grand Rounds. I'm Dr. Lucy Ingram. Tonight we consider a complex case in endocrinology and renal disease. Discussing the first presentation tonight, we have our panel of experts consisting of Professor Scott Kitchener, experienced rural GP, Medical Director of Queensland Rural Medical Education, Clinical and Academic Lead of Rural Health at Griffith University and Research Lead in Agricultural Health in Medicine Research at the University of Southern Queensland. Welcome, Dr. Kitchener.
Thanks, Lucy.
We have Dr. Shelia Cook, Staff Specialist Endocrinologist at Toowoomba General Hospital. Welcome, Shelia.
Thank you, Lisa.
And Lisa de Jong, experienced podiatrist from Podiatry for Foot Health in Toowoomba. Welcome, Lisa.
Thank you.
Can we please welcome our specialist and expert panellists? As usual, we are being live streamed around Australia. We have a number of participants watching remotely, so I encourage you all to join the discussion by emailing your questions to grandrounds@qrme.org.au, or you can tweet your questions using the hashtag now on your screen. Our presenter tonight is Dr. Hilary Vincent from Emerald. Please put your hands together for Hilary.
Get started, okay. Well, good evening everyone. My name is Hilary Vincent and I've come down from Emerald today, where I work as a GP registrar specialising in paediatrics. Tonight we're going to discuss a case about type 2 diabetes, and I've chosen this case very specially because it deals directly with the challenges that a patient facing type 2 diabetes and therefore his GP will face together when they're trying to work on the management of someone who has a very well established case of type 2 diabetes. But first, we've got a few slides to get us warmed up and then we'll dive into the case. I suppose I need my clicker.
I think it's behind us.
Yep.
Affirmative. All right. So, type 2 diabetes, again, largely preventable. It's a chronic progressive condition, and basically it results from two metabolic dysfunctions: insulin deficiency, which can often be on the background of insulin resistance. Did you know that in Australia right now there's just over 23,500,000 people, and of that 4% of them will actually be affected with type 2 diabetes, and this has doubled in the last 20 years. In addition, 1 in 6 people will also have some abnormal glucose tolerance. So we just need to start thinking about these types of cases because they're going to be coming into our consult rooms. They are going to be presenting with what we are seeing as an epidemic of obesity in our population and changes in our lifestyles to more sedentary, to more of a sedentary lifestyle. So we've got it affects males more than females, and we can see that 96% of them will be over the age of 35 and 43% will be over the age of 65. When we're thinking about what happens when you get type 2 diabetes, we know definitely we're talking about cardiovascular disease, we're talking about all of the microvascular complications in the smallest blood vessels that we have, which are in our retinas, which are in our kidneys, which are in our skin. And it also makes up part of what is a multi-morbidity. So type 2 diabetes will quite often be part of a constellation that you'll see in your other patients as well. So to have a think about what we've got available to us to help us out with these patients, I would like to introduce tonight, we've got a new RACGP general practice management for type 2 diabetes for 2014-2015. This includes the AUS-D-RISK, and this is a 5-year predictive calculator, and it talks about gender and diet and if you've got hypertension and what your family history is like and what your waist circumference is like. And scores over 12 and over are high risk, and of course the scores do go up much higher than that, basically coming down to about a 1 in 3 chance of you developing type 2 diabetes using this calculator. Very importantly, I think that we need to start considering what is clinical governance. we've got a huge problem on our hands in facing type 2 diabetes, certainly into the future. And we need to have a way that we can actually keep that high level, a high standard of care and continue to improve it. And I think that this is one of the ways that we do that. We get together, we do case presentations again, and we have a wonderful expert panel to talk us through some of these issues. So the biggest thing that we discovered, and I did have the most wonderful opportunity to present part of this case with our doctors in Emerald, including the hospital doctors and the GP doctors. And one of the biggest things that we came down to was being able to communicate, being able to affect change. And so perhaps as part of our clinical governance, while we have a look at the guidelines, while we do all the right things and we order the right tests and we refer to the right people, we also really get right down and we're communicating with our patients in the best way we can, really getting that relationship, a steady relationship going with them. So, most importantly too, through this identification of these at-risk individuals, it is possible to prevent and or delay the onset of type 2 diabetes. And that's really important. Like, you go to the doctor and you've got an illness, and as we'll see tonight, we have to get to these people early because type 2 diabetes gets complicated, and it gets complicated for everybody. All right, so let's get started with this case. So tonight we're talking about a 57-year-old man who presents to you in your GP practice, and he's got a sore right foot. He comes to the practice, but he hasn't been for ages, and so you weren't sure what he might be coming in with necessarily, but it could be anything. Having a look at his foot, and when he shows you, he says, oh, look, it's got a bit of an ulcer on it, and, I don't worry about it too much, but it's gotten red, and I think there might be some pus coming out. And he hasn't been feeling very well, and he's had a bit of a fever. So his past medical history, as we said before, is a man who has got type 2 diabetes. He's had it for 23 years. He's also centrally obese, has hypertension, high blood pressure, high cholesterol, peripheral vascular disease, some depression and gastroparesis. We'll just take a minute to have a look at his medications that he's on. And I want you to consider as well what types of dosing we're seeing in these medications and what these medications are for. For example, the metformin at 2 grams a night, this is going to be an issue. Something else to really consider, given that he's got some of this depression, like we're looking at this case the first time as GP registrars out there saving the world, one type 2 diabetic at a time, is mirtazapine like a good medicine to be on? Just because of its weight gain, like possibilities or complications. He's also has a couple of beers a night. He's an ex-smoker. And importantly, socially, he's unemployed. Why? He was a truck driver, but he couldn't keep working because he had poor diabetic control. And he's divorced as well. So if we have a think about this man in general, we can see him sitting in our consult rooms. He's not a happy guy. He can't work at the moment. Having a bit of depression and having quite a burden of medication that he's on too. All right, so we go forward and we want to examine him. So he's got a low-grade fever, his blood pressure's up still, even though he's taking, some of those medications for blood pressure. His BMI is high, and certainly his waist circumference is larger than we would like it to be. And having a close look at his foot, we notice that he's got quite a deep ulcer on the plantar aspect around his metatarsal phalangeal joint. It's surrounding it is cellulitic, and we have a feel for his vasculature, and it's difficult to identify the pulses of his feet. Also in sensation, we can see that he has poor sensation in his foot, which he sort of said like he wasn't sure about. It wasn't too bad, wasn't bothering him. It's just that has it got pus coming out of it? Is that bone? Not too sure. It wasn't too bad, but this is this guy's foot. Can you see it? So certainly we've got, on view, and I'll definitely leave it to our experts to discuss, but certainly looking at this one, there's some criteria. We're talking about larger than 2 centimetres in diameter. We're talking about depth. We're talking about cellulitis. So this man needs our help, and so we step back and have a look at him. So we can't necessarily just rush off and say, okay, quick, just go to the hospital. I don't want anything more to do with you, because today you've got an acute issue. So we'll deal with that in a second, but let's have a little bit of a talk about what's been going on for you. So he says, I don't always take my medicine, especially that metformin. It really makes my tummy feel sick. And those needles that you want to give me, every time I eat and stuff, I don't really like them. So I don't always do them. All right, doc, you caught me. We did a GP management plan for him a little while ago. But sort of like in Emerald, if you live somewhere like Claremont, it's hours to drive in. So he was happy to come and have his doctor's appointment, but then it also meant he might have to come in 5 more times, trying to work out that with cost, etc. He's not working. You can see where this is leading. He also doesn't want to see a dietitian, no, because they're going to tell him that he's not allowed to eat the stuff that he loves. But because he was getting a bit worried about his health and stuff, he thought he'd buy some new running shoes, give it a go a few times around the block until he noticed the wound. And I just want you to have a special note there. It wasn't so much that he was feeling it in his foot. He saw it. It was starting to get red. All right, so we look back in his chart and we ask ourselves now, this guy, he's got obviously a foot problem today. He has type 2 diabetes. He's got some comorbidities. What are the investigations that we've done? So in the vascular bracket, we can see that there was an ultrasound that was done last year, and it does show bilateral peripheral arteries being atherosclerosed. His last bloods, his HbA1c was 9.9. Electrolytes essentially normal, and importantly in that bottom left-hand corner there we see his EGFR at 46, creatinine at 173, and urea at 9.9. LFTs, he doesn't have that sort of hepatocellular picture yet, but he certainly has got a raised gamma GT and LDH and ALP, otherwise normal, and his cholesterol is up. And we wonder as well with his good cholesterol or his HDL cholesterol being down, is that a hereditary thing? We know we're obviously not managing this man very well at the moment, even though we've got him on lots of medicines. So for this guy, in this case, he was commenced on Augmentin Duofort. An urgent x-ray was ordered, and we called straight through to Rockhampton to have an orthopaedic opinion about what's going on. I just wanted to make a mention here, and this is part of what this case is about having a look at evidence-based medicine. In the guidelines on UpToDate and certainly e-therapeutic guidelines, Augmentin Duofort isn't a great choice, especially if you've got a clinical suspicion of osteomyelitis. Sure, we can start to try and treat the cellulitis and bring it in and perhaps starting something you might think would be good, but actually the guidelines ask if you could get a tissue sample of what is infecting that particular ulcer at the time, then we can have much more directed therapy. Is an x-ray the right thing to do? In fact, it's a very good thing to do if you're looking for osteomyelitis, because you'll be able to see some fraying of those bone edges and be able to give you a bit of an impact as to how much of this foot has been affected. And of course, we have to call ortho and let them in on this whole thing. So they requested that we repeat the bloods, and which we'd already done, but really specifically, they wanted us to add an ESR. So the full blood count was all done, HbA1c, urine microalbumin, CRP, and ESR. So the ESR is really useful in identifying how we're getting better. It's something, CRP is acute phase and ESR lasts for longer, so it helps us to track his inflammation process around the healing of that foot. So we've got him set up to go now, probably with that rural context in mind, probably by our local hospital, and then to be transferred to the nearest ortho for an opinion and management. And of course, as he's walking out the door, you're saying, hey, look, you know, you need to come back. You need to come see us. We need to get this sorted out. And this is, of course, when we want to do our referrals to our podiatry, and we would like a new GP management plan. And we really need to with this particular gentleman. And wouldn't it have been nice 20 years ago to have been able to be that GP, that I was identifying these issues as his blood pressure was creeping up, as, you know, his blood tests may have been coming back a bit deranged, been able to really start having a look at him, his diet, his lifestyle. Now, we all say that, right? Like diet and lifestyle. But in type 2 diabetes, with good management, we can actually, you know, regress a lot of the protein being lost through the kidneys. It's quite interesting. So I suppose high yield here, first take-home point is we've got to get to these guys early. All right, so orthopedics have him. He did have localised osteomyelitis, and he was given some appropriate antibiotic therapy, which was then followed by some oral therapy, trying to maximise him, because the biggest problem that we have that this man will face, and as I said before, as doctors in the hospital or as his GP will face with him in trying to manage this complication of type 2 diabetes, is that he's got vascular complications, he's got not well managed diabetes, he's a big surgical risk. So trying to maximise, or what's the right word, but yeah, trying to optimise his therapy, unfortunately, with consultation with the vascular surgeons, they decided that they needed to do a 4-foot amputation. So this is basically where you can either just have all of the toes removed, or they can even do one where it's halfway up the metatarsals, and so you'll end up with, you know, quite at the front, four of your foot missing. But there are excellent, I understand, excellent boots that actually you slide that part of your foot into, and it has a replacement end, so you can still wear shoes, open-toe shoes. I had a little bit of a look into it. So he was in hospital obviously for quite some time. He would have been with, you know, the hospital dietitians potentially, and podiatrists and everybody helping him. So, but he comes back home. And yes, he did engage with the plan that we had in mind for him. And he attended 3 out of the 5 appointments. He saw an optometrist, he saw our diabetic educator, and he also had a medication review. So after reviewing those medicines, it was decided that it would be really good to have a Webster pack for him so that he does take all of his medications. We wanted to increase that, antihypertensive therapy. It was decided to continue him on his metformin at 2 grams per night. And then we were wanting to seek some advice in terms of alternatives to insulin. And I guess for us out in Emerald and maybe in other rural places, and not knowing, you know, this guy's, all of his situation, but not working, did you know Webster packs cost an extra $10 to be done? If he wasn't taking the 2 grams of metformin before, why would we leave it on it? Why would we leave him on that higher dose? He wasn't taking it. Maybe he's never taken it. Maybe we've snuck, you know, our medication dosing up a little bit prematurely. These are some of the other things that, you know, could be considered with this particular man's case. All right, so this is the end of the first half of the case. So we're going to go to our panellists now. So, like we said, so many things. Where to start?
Thank you, Hilary. So if everyone would like to thank Hilary for the presentation. And was there a question that you wanted to ask to begin with about this case of the panellists?
For us, I think that what I started to say just before, which was, you know, what about, you know, with medication dosing, if we are given a situation like this, is it actually a good thing to do, like to be able to reduce some of those things? Do we start again? Do we just bring it right down? Or do we just try and not make him compliant? You know, because compliance is an interesting word for medication use with doctors, but we want concordance. So in order to capture that concordance, can we just take metformin out altogether for a while, maybe?
All right, so if we should start perhaps with Sheila, would you like to take that one on?
So thank you, Hilary, and thank you, Lucy. Look, he's got some terrific issues which are very common, and I think the approach to it, in my mind, I've totally changed the way I practice. And I think there's a lot of evidence that the diet advice that I'm going to offer him is very different now than it was even 2 or 3 years ago. And I think the dietitians are moving in really interesting directions around that. There's some good data about diet, and I think we can re-engage him. So there's actually some really good news. So some of the foods that I would recommend are totally the opposite of what we've said in the past. So I'd actually lead with the good news. Clearly he comes in feeling terrible and ready to be beaten over the head because that's probably been his experiences in the past. So I think in terms of addressing his issues, it's trying to pick out the bits that will give him some positives. So sure, there's some food discussions I would like to have, there's some medications I'd like to discuss, and I think we could really change his medication regimen quite drastically. But really at the beginning of it is, what do you want out of this? What are going to be motivated by? What is it the thing that worries you most? What is it the thing that you enjoy most? And actually tackle those things. So that's how I approach my diabetes consults. So if he says to me, I don't want to see a dietitian, that's a beautiful red flag for me to go, okay, he's had some negative experiences. Let's build on what's been positive and take away the negatives. So I kind of approach things like that. But if I'm going to pick out the medications, I actually have about 5 or 6 ideas about how I'd approach his medications and have some changes. And I think one step at a time is going to be important, but his situation's critical. And he's got immediate decisions that need to be made. When I see an HbA1c that's higher, higher than 8%, I'm suspicious that he's actually not taking his insulin at all, and I'm suspicious that he wouldn't be taking his metformin, so I frame my questions around that. So first of all, I'd say, a lot of people forget to take their medications. Is that the case for you? Do you often forget your medication? So it gives them the opportunity to say, it's okay, I'm not here to judge you, I'm here to help you. Let's talk about what you remember and don't remember. So I frame my questions like that to give that open opportunity to be a discussion rather than a whacking exercise. So most of the patients, I assume, never take their metformin because the side effects are awful. No one ever takes a lunchtime dose, so I never start a lunchtime dose. It's always once daily or twice a day. And the maximum is 2 grams. But in him, this chap's got an eGFR of 46, so whether that's an acute or a long-term prospect, then I'd be actually looking to reduce his dose either because of side effect profile or actually the ideal dose for metformin in someone with renal impairment. That being said, we're actually questioning the idea about metformin. I think there's more studies coming out saying people on dialysis are being given metformin quite safely. So I think we're questioning the whole data around metformin and renal failure. So I'm less worried in someone who's got stable renal impairment, and if we need it and they can tolerate it, I do escalate the dose but be very careful about it. So the metformin idea, in the first phase, I'd be getting rid of it altogether in the setting of sepsis and then reintroducing it once that's resolved. I would always stop it in the setting of someone going for surgery and then reintroduce it once that's, he's recovering. But in the long-term planning, I think I would continue the metformin and go for the dose that he's most happy with. Once a day, it's always once a day I go for diabetes because it's so much easier to remember. And it's always a nighttime dose. If you're going to have nausea, you may as well sleep through it. So that's how I approach that. With the insulin, I know he's not taking it, but I'd also be very concerned about BD Lantus. If it's something that I'm really worried about right now, certainly in our district, is twice daily Lantus. I'm finding so many people having so many hypos. We've had admissions to hospital with fractured neck of femur and no one's mentioned the fact that the fall was because of twice daily Lantus and overnight hypos. I saw a man in Kingaroy who crashed his car because of having hypos and no one had actually kind of changed the BD Lantus to once daily. So if there's a take-home message for me for this chap, anyone who's got renal impairment, it should be a morning dose of Lantus, never twice daily. That would be my other intervention. And if someone's going to remember once, the beautiful thing about Lantus is it is once daily. It was never actually registered for twice daily use. So once daily is the most appropriate way to use Lantus. And anyone who's frail, so that may be an age older than 65, someone with renal impairment, someone with hepatic impairment, or someone with cardiac disease, it would always be a morning dose for me, okay? And I'd immediately stop his nighttime dose. Gosh, I gave myself insulin during pregnancy recently, and it was a pain in the neck to have to remember it. So I was thinking, I'm giving people 4 and 5 times daily insulin. That's terrible. So if you can simplify it for a man who's just trying to reintroduce himself to self-care, because he's already bought the running shoes, so he's committed, let's make it simple. So once daily Lantus, once daily metformin. Can I keep going?
Absolutely.
What do you think about adding some sitagliptin or agliptin?
So the PBS doesn't allow you to. So if you look at the PBS prescribing, you're really only allowed to use sitagliptin in combination with metformin and or sulfonylureas, not with insulin. Now there's fantastic studies that show that sitagliptin or these DPP-4 inhibitors are wonderful in improving not only the insulin secretion, but improving insulin sensitivity, and that's fantastic. And so people who are on basal insulin, you could actually add a sitagliptin, one safely and two really effectively, but Tony Abbott doesn't want us to do it. And I think it's all about taking care of our budgetary, requirements and thinking about how we prescribe these wonderful but very expensive new therapies. So keeping that in mind, I recommend, these are the types of choices we make, but recognising the efficacy, and overseas there's some beautiful, there's a lot of widespread use of these combinations quite safely. So I think it's a good idea, but I would actually prefer to give him a talk about diet, which I'll come to as well. So in terms of the foot and the antihypertensives, I've actually also made changes, again, thinking in mind what would he remember and what's most efficacious. But I actually have all of my antihypertensives a nighttime dose. So there's some really interesting data, and it's called chronopharmacology, which has identified that if you actually dose your once daily regimen to the time of the day where it's most efficacious, it actually makes a bigger difference rather than changing the dose. So all of the antihypertensives have actually been shown, if you just simply change one to a nighttime dose, you actually reduce the blood pressure without adjusting the doses. So again, almost wholesale, I'm changing most of my antihypertensives to nighttime. One, because it's more effective, but two, you actually reduce that postural dizziness that people get during the day. So I would make that change for his ACE inhibitor. And I would challenge the amlodipine, because I saw his foot and it was terribly edematous, and amlodipine is notorious for causing edema. So actually now no longer use amlodipine in people with critical feet, so I wouldn't use that one. I do like calcium channel blockers, but I'd probably go for leucanidipine as my preferred option and start as a nighttime dose. So that's how I'd approach him. In terms of therapies that you're worried about for weight gain, you mentioned earlier, Hilary, weight gain in terms of the antidepressant that he was on, but beta blockers, will also not so much cause weight gain, but cause insulin resistance, so actually worsen your glucose control. So I'm always very cautious about giving people beta blockers if they don't need them in diabetes. But the other concern for beta blockers is it causes vasospasm. So unless it's cardiac specific, I actually also stop beta blockers in the setting of peripheral vascular disease. So I actually opt for other alternatives. Okay. And lastly, I saw the hydrochlorothiazide was added. Again, a very good antihypertensive, but will also increase your glucose. So it actually increases insulin requirements. So keeping that in mind as well.
That's fantastic.
Thank you.
If I can ask, Scott, your approach to a patient like this with so many complex issues.
So I'm not clear where he lives. Does he live in Claremont or does he live in Emerald?
He actually he lives in our area. He's sort of in between. This is a case that is taken from a colleague, so yeah, he's out of town a bit.
Is he now in Emerald Hospital or is he in the practice at home?
No, so this was a case that was from a while ago, so he's at home now.
I find when they come back from a tertiary hospital, particularly if they've had an orthopaedic admission, you really need to see them soon. And certainly at Clifton we would be, if the opportunity exists, we try to transition them from the tertiary into the hospital, into our hospital, and then normalise their medications to that which is reasonable for them to continue at home. Because the reality is most of their care is going to occur at home, and unless the care is suitable for them at home, and he's living without a carer, so I think there is a high risk. And I thought he was still on Nova Rapid, and he went to Rocky, I gather, on Nova Rapid. He didn't come back on Nova Rapid. He came back on Lantus.
Yes.
Yeah, I mean, orthopods aren't noted for their skills in endocrinology, so I would certainly be looking to see what we would do. I think there's other things you can probably look at. Things like if he's living alone, I'd probably be looking to explore whether or not we can get Blue Care in to have a closer look at his wound management. And if he's running, I think you've got to consider putting him with, in Emerald, I'm sure you've got, it's a big town, so you've probably got a gym there.
Yes.
And, it would be worth going and having a word to the guy that runs the gym, who's probably not an exercise physiologist, but at the very least, if you can hook them up with a visiting podiatrist and get them sensibly looking after that foot, because if he gets back into exercise,
which we want him to do,
and I'm sure, the the foot's the high risk. So I'd be really cautious about how he fits back into his community. If he's bought some shoes and he thinks he can just, he's 25 again and he can just go straight out and running, you're asking for a lot of problems. To me, it's about how he fits back into the community. And Emerald's fortunate. It's a big town and you've got a lot of resources. I think I'd really be mobilising those. The other one that I'd think about, even though he might be unlikely to accept it, would be somebody who actually manages his diet. So Meals on Wheels may be interested in assisting him, or the converse would be to get him involved in Meals on Wheels so that he's thinking about his diet and he's contacting people that are involved in dietary management. And, that way he can start taking control of his own condition, and I think you've got to do that.
Yeah.
So, but I think the foot's the high risk at this stage.
Yes, if we can ask Lisa, sort of, with a case like this, with a patient with, a terrible diabetic foot ulcer, what do you do in your practice as a podiatrist for patients like this?
Okay, it probably depends a little on at what point you see some of these clients. Some of the clients will self-refer themselves, so they, might present with that wound prior to seeing their GP. It's amazing. Some of the clients will be really quite embarrassed about showing people wounds like that, and they're just appalled that it's got to that stage and that they haven't noticed. So it depends a little bit at what point they present. My usual proceedings would be to take a subjective history, so to find out, sort of what's led to this, and of course in this instance there was some link with new shoes, and that may not be necessarily just be the fit of the shoe. It may not have been that the shoe was too tight or too big or too small. It might actually be the way he's functioning in that shoe. So I'll look at what led to that ulceration from his perspective, look a little bit at his medical history as well, medications, ascertain who his GP is and what other members of the healthcare team are involved in his care at this point. Then I'll start to have a closer look at the foot and look at things like the nails, the skin, the hair distribution, changes to the skin, so where there might be hyperkeratotic lesions, where there's evidence of pressure areas developing. And then I'll look at very closely at footwear and try to get an idea of what sort of footwear they generally spend time in. People often wear quite different shoes when they come into my office as to what I think they probably wear most of the time. So you're sort of having to quiz them a little bit about the sort of work they do, the sort of activities they perform around the home and the garden, and what exercise they might participate in, and that you start to get a bit of an idea as to what sort of footwear they generally spend most of their day in. I'll always look at the shoes quite carefully, the inside of the shoe, take the insoles out, because you can see a lot from the insole. You can see where pressure areas are developing. You can see the wear and tear on the inside of the shoe. I often put a hand in the shoe and feel what's in the shoe. Broken linings, pegs, matchbox cars, thumbtacks, all those sort of things can be inside that shoe, and the person will be completely ignorant of that. Turn the shoe upside down, have a look at what sort of wear patterns are emerging on the shoe. Have a look at the way they wear their shoes. And again, often people come in, their shoes are nicely tied up, the laces are beautiful, but there's often evidence that that's not how they actually wear their shoes. And particularly if we're talking about older people with obesity, if they've got lace-up shoes, how do they get down there and do them up? Typically, if I can demonstrate, people who have difficulty getting down to their shoes will often do this sort of thing, trying to do up their shoes. So as soon as their foot's not in the shoe correctly and they're trying to do it up, then that shoe's not going to lose an appropriate fit. It's not going to fit in the way that it's really designed to fit. So I look very closely at footwear because it's such an important protective behaviour to wear a shoe properly. I'll then start to quiz them about some of their other activities, what exercise they enjoy doing, what exercise is convenient for them, what exercise is comfortable for them, because I think those sorts of things are really important rather than saying, well, look, you really should be doing this type of exercise. I think you need to get to know what that person is going to enjoy doing and realistically take part in. Then I'll start to look at the evidence for vascular disease and neuropathic change. So I might, I will always palpate the pulses, because I think that's part of the education process, is actually putting hands on the patient and saying, well, this is where we should feel the pulses and this is what it should feel like. Also feeling for temperature, you can feel skin changes, things like that as well. I use a handheld Doppler because, again, I think that's a great educational tool, and people get such a kick out of hearing those pulses. And I have a readout on the Doppler so that I can show them as well. They can hear it, they can see it. So I try to incorporate that into the education process. Then I'll look at the evidence for neuropathic change. I use a monofilament. And do some testing with that. I use a tuning fork because, again, it's just part of that education of the patient that, you know, whether or not you can feel vibrations, not, you know, particularly important, except that that might be the first sign of neuropathic change in that client if they're not able to pick up on the feel of a tuning fork. I'll use sharp blunt sometimes too, just to point out that there's different nerve receptors, that we're all really attuned to picking up on pain as an indicator of injury or, you know, loss of sensation, but we're not necessarily attuned to the other sorts of change in nerve receptors. And I suspect in this instance there's a lack of perception of pressure, so that's a difficult one for people to really appreciate. So I try to give them a little bit of an indication of the different types of sensation that they should be feeling, that they're not just waiting to feel pain. I think where podiatrists play, you know, the biggest role in managing diabetic feet is often in picking up on biomechanical changes, so changes to the way that foot moves or the way the person moves. So, like in this case, the way it's been presented, we can assume that the vascular investigation occurred well before the podiatrist was involved. So we can sort of assume that that's, you know, all in place, that there's a plan for managing those sorts of changes. So in this case, I would perhaps consider that my greater role is in monitoring some of the changes in foot posture and biomechanics. A lot of older people and obese people, their gait patterns change, and they start to you know, move in different ways than they would have when they were much younger. Typically their gait or their base of support increases, so their feet will be further apart. If you think about the way very big people move, they often use a lot more lateral movement than forward progression. So their feet are usually further apart on the ground, and they tend to have a more swaggering gait. That changes the pressures that you can expect to see distributed across the plantar aspect of the foot. And that's a really good guide in combination with looking at the foot and looking at the footwear as to how that person moves, and as a bit of a predictor of how we can manage repeat pressure problems. I guess the other half of the story I don't think has been told, in that we've only seen the right foot and there's a left foot there as well. And I think probably in this case, the left foot's now the high risk foot, because he's going to always limp. He's always going to favour that foot, and he's probably always going to have a little bit of a, you know, a problem, you know, thinking about, you know, how he's walking with that foot. You know, that he's...
His BMI is still over 40.
Yeah.
So his knee's probably going to be buggered too.
Oh, exactly. So, yeah, we're probably looking at arthritic change in the knee, and that changes the way he's going to be walking as well. So I would be really trying to bring his attention to that left foot, and because he's going to be relying on that foot a lot more. And I think the difference for a lot of people's lifestyles is, you know, what happens to that other foot, that he might manage with a partial amputation on the right foot, and, you know, with some assistance get back into some of the things he enjoys doing, perhaps, you know, start looking on the brighter side of life. But once those problems start to occur on the left foot as well, that's when life really changes, I think. So
So I think it really influences. I think you make some excellent points, Liz, because these patients often can't walk. And so we're now paying a lot of attention to upper body resistance training because that's actually emerging evidence to say walking actually gives you no glucose benefit whatsoever for diabetes. And this is in total contrast to everything we've been telling patients. And so this poor man who can barely walk, the good news is he could actually start using his upper body strength and actually gain better glucose control than if he was walking anyway. And so what we've also found, we're now running a high-risk foot clinic, our patients are in the situation where they cannot exercise, and so they're doing upper body strength and they're improving the vascular supply in their feet. And this is something that was really unclear to me, and it's, you know, there's good evidence to say that you actually increase your vascular endothelial kind of growth factors, and so you actually promote improved vascular supply in the entire body, including the lower limbs. So we've got one lady who, she was smoking, doing all the wrong things. She started just lifting her baked bean cans, didn't go to the gym because she couldn't afford it. So we got her lifting, got her doing upper body strength, and she actually gained improved vascular supply in her compromised feet just by upper body training. I thought it was really quite remarkable for me. So I'm getting everybody to do the same thing. So, and the other, for those people who can walk or don't want to walk but want to feel good that they're doing good exercise, actually just standing up in the ad breaks of your television program give you just as much benefit in terms of glucose and insulin benefit as walking. So if you want to improve your glucose control, avoid your diabetes, you don't actually have to join the gym or walk around the block. You just stand up in Neighbours or whatever people watch. So, you know, that actually just gives you just as much benefit. If you really want to improve it, then you kind of might stamp on the spot or, you know, do some exercises, some squats or something like that. That gives you much better glucose benefit. So, you know, for this chap, you know, if he can't walk, then all is not lost. If I could make a point about the foot ulcer, you made some excellent points, Hilary, about the imaging and how we interpret the ulcer itself. I would also suggest doing a plain film will look for foreign bodies, and so that would then dictate, you know, a surgical intervention if you find a foreign body on a plain film, and that would always be the first test, looking for foreign bodies apart from the osteomyelitis. And the other thing about the antibiotic choice, you could swab, you know, till the cows come home, but the correlation between the surface swab and the actual causative organism is about 20%. So there's really no benefit to doing a superficial swab. You wouldn't change your management based on that result. And furthermore, most of the time it's Pseudomonas, and Pseudomonas responds nicely to vinegar. You don't need to treat with antibiotics, and it's a commensal organism that just kind of seems to jump in and play around on the surface without necessarily being pathological. So we use acetic acid. You could just drop in some vinegar into your warm water and soak your foot in that once a week, or, you know, once daily if it's a really big green smudgy, you know, pus-ridden ulcer. So we're finding that's probably more effective and obviously safer and good for the naturopath. So
yes, that's amazing.
Thank you. That's really, yeah.
If I can ask you, Scott, just with a case like this where there's a lot of chronic disease and obviously this patient needs a lot of support from a multidisciplinary team, what are your comments on this patient, you know, with a GP management plan and a team care arrangement? How are they best used in this circumstance, or are they good for this patient?
They're good if you've got the people to refer to. So you can't actually use a team care plan unless you've actually got a team. And so you're lucky in Emerald. I mean, it's about, I understand it's about 14,000, 15,000 now. So you've probably got people that you can actually use. It's not uncommon for us to use the practice, one of the practice RNs as one of the team, and they don't necessarily, it's great if they've got diabetic educator training, but just simply sitting down with someone on a regular basis who can look at their wounds and can check their circulation, can talk to them about how they're going, and I certainly use them as a general health professional counsellor, and I think that's worthwhile. We're lucky in the town I work in, which is less than 5,000, we get visiting allied health, and that's, you sort of go with the visitors you get. So we get a dietitian, and I've got to say, everybody doesn't want to see a dietitian. It's really difficult, I think, for the dietitians to go and get business. And I find that if you can ease people into their taking responsibility for their condition, and I think that's where then they want to see other allied health. And for some reason, patients see podiatry as a really hardcore, objective, and they can see the issues. The other one that I commonly use is we have a visiting optom, Most of my patients can't afford to see the ophthalmologist. Nice guys as they are, they're unaffordable for the majority of patients. And as far as I'm concerned, as long as I can get a good retinography, and particularly comparative retinography, I think is incredibly powerful when you're looking at long-term patient care, because you may not have the ability to sensitively pick a retinal change, but if somebody gives you a photograph and then gives you another photograph that has been taken a year later, what's different in these images I think is much more powerful. So I tend to use optoms that'll do retinography, and many of them where I'm at that are sort of within 60 or 70 kilometres will do it on a long Medicare consult, which is fantastic. So I think the GPMP and the team care arrangements is a wonderful move by the government. And if you're listening, Prime Minister, I think you should carry on with this. But I think there are limitations in terms of actually being able to access allied health, and we probably need to make it more financially viable for allied health. It would be my general comment, because I think that's probably now the limitation we're getting to, access and viability for allied health to actually use it.
Excellent. But I think the relationship that you have as the core, contact for these patients is so valuable. And whether that's you in partnership with the patients or the patient's family and the practice nurse, that alliance in itself is a care team, really, isn't it? But I would like, if I could, just speak about the food either now or later.
Yeah, absolutely.
So the evidence is completely in favour of foods that you're going to love. And so, and again, I put this to the patients that, what we've said about milk was wrong. So full cream milk has actually been shown to actually improve your vascular outcomes and improve your, not adherence, but your weight loss potential if you're, going on a weight loss diet. And the theory behind that is the fat in the milk seems to stay in your mouth, so you're less likely to snack on the foods that make you gain weight and make you have high sugar levels. So, but interestingly, the fat in the milk doesn't seem to cause hypercholesterolemia in the same way that we've been led to believe. So when they've done studies looking at long-term outcomes, they're just observational studies, but compared to a reduced fat milk, full cream milk seems to be associated with lesser risk of cardiovascular death and cardiovascular disease. And it probably boils down to not so much the fat, but the way that the low-fat milk has been modified with high pressure, high temperature to remove that fat. It becomes a really inflammatory food. And so it probably increases your likelihood of atherosclerotic disease. The other foods that I'm a big fan of, and most of my patients love it too, a combination of baked beans for fibre and eggs. Eggs have actually been shown to reduce the likelihood of developing diabetes. So you start talking about that, and I know the dietitians go, you can only have 8 eggs per week, which I don't know if I could count that out, but there's actually no limit in the studies that I've looked at, looking at observational studies on the egg eaters versus the non-egg eaters, and the egg eaters had lesser risk for heart disease. So I think that's great news. The nut studies, there's a whole lot of nut studies that show you reducing your risk for heart disease by about 25%. Sorry, not heart disease, but diabetes. So if you're trying to prevent diabetes or reduce your glucose levels, nuts seem to be the go as well. So I think there's a whole lot of interesting foods. The things that I'm probably a little cautious about is overcooked red meat. That has been associated with higher rates of heart disease and diabetes. But vegetables you can't get enough of. And the reason about the baked beans is it's the fibre that improves the gut flora that then translates to an improved inflammatory state. So you actually can reduce the glucose levels through eating high fibre foods, and I go for vegetables rather than stodgy all brand, but some people like it, so go right ahead. But it's more the vegetables, so beans, peas, all of the vegetables, but probably and the fruits that are terrific are berries. And avocado is a high fibre vegetable. Who thought? So it's all been associated with reduced rates of diabetes in terms of incidence or control of glucose. So
a lot of choices there.
A lot of good choices.
So one of the issues with rural people is that food security is a greater problem, and so I tend to push towards eggs and tomatoes because people tend to be able to, and in rural areas most people will have access to eggs that they haven't had to pay for. So that's a very popular thing. Red meat's actually less commonly used, and perhaps it's different in CQ. which is the beef capital of Queensland. So.
Not at the moment, it's not, because there's no rain.
So, and I find that fruits are difficult. The fruits that I see a lot of my diabetics getting into, and I saw this guy today who I commonly talk to my students about, and they ran a dairy, and so they're big on milk, and milk's easy to get. But most dairies, certainly the dairies in my family, always had an orchard, and an orchard had lots and lots of citrus. And this fellow, his wife actually patrols the orchard because she knows that he gets up there amongst the mandarins. And typically, you'll see in citrus season, his HbA1c will go off, and she'll be rousing him out. And so I think you do need to look for foods that are accessible, recognising that for a lot of rural people, many foods are not accessible, and look to see what they can grow and what they shouldn't grow. You really have to be in tune with what they're doing. And in fact, I distinctly remember last citrus season last year, this guy actually went so off a beam that he rolled his quad bike, and I'm sure it was because he was having, his diabetes was really off, and so it is important to consider those things. The other thing to look at that we find, particularly where I work, is aged care facilities, particularly in regional areas. There's a lot of aged care facilities. Toowoomba, for instance, has one of the highest populations of aged care facilities. I find it intensely difficult to get reasonable diet for aged care facilities. Wonderful nursing care, and I will certainly use aged care facilities to try and stabilise people back into their community. You don't have to stay in an aged care facility. You can come in for respite. During respite, you can actually do a lot of modification of their medical condition in a way that's a lot safer than if you were modifying it at home. And it may not be the case for this guy, but nevertheless, the dietetic side of it is just a nightmare. And I was going to ask, I actually had a patient recently in one of the aged care facilities we look after, who has diabetes all over the shop, and we actually attempted to use Bietta. I probably shouldn't be using a exenatide, and she really didn't tolerate it well. I'm interested in knowing whether you've had anyone who's gotten any better on exenatide, because I haven't had any luck yet.
Well, there's a little trick, two little tricks. Well, not everybody will tolerate it, so you make an excellent point, but have the injection just before eating and not with a high-fat diet. So it's the fat that slows down the gastric emptying, and gastric emptying is slowed down by the exenatide, and then the metformin stays in the gut longer, and that causes the nausea.
So in terms, well, I was thinking that with this guy who's got a BMI over 40, that exenatide might actually be something I'd go for because of the side effect and the weight loss that's resulted.
If he's not taking the insulin, Bietta would be a good alternative. The only limit is going to be the renal impairment, in which case you'd be a bit cautious, because the studies haven't been done. You know, it's a cut-off at EGFR was 30, so he's 46, so he's got some time up his sleeve, and if he can lose some weight, he might, kind of remove some, improve some renal function as well. So look, I think there's some good alternatives, but again, the whole weight loss thing for his foot is going to be critical. But for the majority of people, there's so much an emphasis on weight that it just demoralises everybody. So it's trying to work out what is the good message that promotes health without making people feel bad. And I think that's a difficult line to cross, a difficult, kind of path to walk. So I think it can be tricky. So.
All right. Well, thank you very much to our panel, but unfortunately we are out of time for the first segment. But we are going to return in 5 minutes after a short intermission to see what happens to patient DM. So if we can all thank our specialist and expert panellists.